Hello everyone and welcome to the second session of antimicrobial drugs or antimicrobial agents, the second session for the introduction or part 2 introduction. In this introduction we are going to speak about the following section here, the choice of antibiotic, appropriate antibiotic, discuss the concept of bactericidal versus bacteriostatic. Uh, uh, we are going to discuss the spectrum of antimicrobial or the chemotherapeutic spectra, combination of antimicrobial drugs. Sometimes we need to combine more than two medication, more than one or two or three medication together to kill the bacteria or cure the infections. The safety of agent. Some agents carry the risk of toxicity. We are going to discuss that. The route of administration, the cost of therapy. For example, we have oral, we have IV, we have IM for route of administration. Cost of therapy. Also, we have some like traditional, prototype antibiotic, cheap antibiotic. We can use it to treat tonsillitis. At the same time, we have some expensive medication antibiotic. We use with the same purposes. And for this reason, we need to take the cost in consideration when you prescribe it to your patient. Some medication present concentration dependent killing. Other medication depends that they're killing the bacteria on the time of you and period of time. We are going to discuss the drug resistance. Then we move to the prophylactic of antibiotic, prophylactic use of antibiotic, and do we have any complication coming from the antibiotic? Okay, speaking about the choice of appropriate antimicrobial or antibiotic regarding our topic about bacteria, we need first to diagnose the infection. We take on consideration patient factors, and we look on the drug factors. So we have to take on consideration several variables when you treat infections. Uh, Okay, the diagnosis of infections. So the first one, we need to diagnose the infections. Diagnosis of infections here. Okay, so as you can see here, we need to differentiate between the community infections, between community infection or hospital infections. Normally, infections in the hospital will be more resistance to the antimicrobial or antibacterial. Does the infections like represent like acute case or like acute infections? Acute infections normally require injectable therapy, like could be IV or IM therapy. On the other hand, chronic infection could be maybe sufficient to prescribe oral medication. No need for the injection here. Also, we need to look on the what type of treatment do you have. Are you going to prescribe broad spectrum antibiotic versus narrow spectrum antibiotic? So broad spectrum antibiotic for empirical therapy or broad spectrum antibiotic for some maybe cases associated with a combination infection. Narrow spectrum antibiotic for when you have selective treatment for selective patient. So when you have narrow, that mean we know the exact infection we have it there, like Enterobacter, for example. If you have Enterobacter, we need to use some maybe specific medication for this case. Okay, the patient factors related to the age of the patient, gender. We look on the if the patient pregnant or lactating women. We take in consideration the weight, allergy, genetic factors, renal function, hepatic function, any concurrent medications. For example, we look on the drug-drug interaction here. Okay, so regarding the choice of the appropriate antibiotic, regarding the antibacterial drug factors, we look on the spectrum of the medication, the spectrum of antibiotic. Is this antibiotic narrow spectrum or broad spectrum? So we are going to learn about this group of medication. Is this medication cover gram-positive bacterial or gram-negative or both? Is this medication cover aerobic bacterial or anaerobic bacterial? is this antibacterial sidal or static? So we are going to explain what that means for us. We look on the pharmacokinetic, for example. This is important because we need our medication to arrive to the site of infections. For example, if the infection in the brain, central nervous system, or in the GI system, or in the respiratory system. So we need to look on the citation of infections, and we need to consider the pharmacokinetic. Does our antibiotic arrive to these organs or not? Adverse effect we also is very important. Drug-drug interaction convenience to the patient. For example, when you have neonates or like children, small children, like infants, we move to the or we prescribe something like liquid or like syrup for the patient instead of tablet or capsule. Cost of therapy also take in consideration. Expensive medication like consider like overwhelmed for the patient, and we need to take the cost of therapy in consideration when you prescribe medication or antibiotic to your patient. Okay, sidal static. What is the difference here? Sidal mean this bacterial, this antibacterial, this antibiotic kill the bacteria. So when you talk about sidal, that means the antibiotic able to kill the bacteria. When you talk about static, that means the antibacterial able to inhibit the growth of bacteria or inhibit replication of the bacteria. So we have the two group of medication. We have antibacterial considered like sidal, killing the bacteria, or static, inhibit growth of the bacteria. We have list of examples here for the medication able to kill the bacteria. Number one, penicillin, cephalosporin, aminoglycoside, vancomycin. This group of medication is able to kill the bacteria. On the other side, on the other hand, the bacteriostatic, we have sulfonamide, tetracycline, chloramphenicol, erythromycin, trimethoprim. Here we're talking about the static with the therapeutic dose. So when you prescribe therapeutic dose to your patient with this medication, consider like static, inhibit growth of bacteria. Sometimes when you prescribe high dose of this medication, when you prescribe high dose of this medication, the result will be killing the bacteria. So it depends on the dose of the bacteria. If you prescribe therapeutic dose, that could be inhibit the bacteria. With a large dose, a high dose, this will lead to this group of antibiotic will move from static to the sidal. Okay, spectrum of bacteria. We have some maybe example here for narrow spectrum, extended, broad spectrum. Example here, narrow spectrum. We have isoniazid. Isoniazid, this type of antibiotic used for mycobacteria, especially we talk about tuberculosis. And for this reason, isoniazid will be used mainly for the specific single type of microorganism. Here we talk about TB, isoniazid. So we don't use it very popular in the infectious disease. Isoniazid mainly used for tuberculosis. Extended spectrum, here we have some medication could be used to cover the entire gram positive. For example, here we have ampicillin. Ampicillin active against the gram positive organism, also may cover some gram negative bacteria. So ampicillin mainly cover the gram positive organism. Speaking about the broad spectrum here, that means effective against wide variety of microbial. Broad spectrum, we have tetracycline, then we have chloramphenicol. So it depends. You can see here category for the chemotherapeutic agent according to their efficacy. We have narrow spectrum, extended, broad spectrum. Okay, moving to the combination of antimicrobial drugs. Normally, we prefer to treat the patient with a single agent. So we don't prefer to use combination therapy. It's better to treat the patient with a single therapy because it's more specific treatment. It's most specific treatment, reduce possibility of super infections, and decrease emergence of resistance organism, and minimize toxicity. This is all these maybe justification for using single agent, single or like monotherapy. We prefer to use antimicrobial or antibacterial monotherapy for the patient. We don't prefer to use a combination therapy. Number one is it will be more specific to the organism. Number two will be less possibility of super infections. Number three, less maybe possibility of drug resistance and less toxicity. We have some example here for combination therapy. If the patient suffers from tuberculosis, we go with the combination therapy between several medications to cover the case. If the patient suffers from septicemia and the patient is critically ill, we use combination therapy such as penicillin and aminoglycoside. Here's some examples. So number one, tuberculosis. Number two, septicemia and critically ill patient, we use ampicillin, penicillin, and aminoglycoside. Then, if the patient suffers from pneumocystic pneumonia, carinic pneumonia, we use cotrimoxazole, this combination of sulfamethoxazole and trimethoprim. So this is a kind of combination effective in treatment of pneumocystis carinii pneumonia. If you have like mixed bacterial infections, when you have like for example bowel perforation or like abdominal surgery, um, normally abdominal surgery here, and we have contamination or infections in abdomen, we use mixed bacterial infections. Okay, so here we have some advantage and disadvantage for combination treatment. For example, advantages here when you use beta-lactam such as amoxicillin and aminoglycoside. This is synergism combinations. For example, here when you have penicillin, penicillin destroy the cell wall. Okay, penicillin destroy the cell wall. Okay, destroy the cell wall, the penicillin, and this will allow aminoglycoside to enter the cells and inhibit RNA. So now you can see here beta-lactams such as cephalosporin or penicillin destroy the cell wall of bacteria and facilitate entering the aminoglycoside to the inside the cell wall and inhibit RNA. This is kind of combination therapy synergistic effect. So combining beta-lactam with and aminoglycoside when you have severe infections, that will be great for the patient. Okay, moving multiple drugs used in combination indicated only in special situation when we have infections of unknown origin. So the patient come to the hospital and we don't know exactly the origin of the infections. The situation could be risky for the or life-threatening infections. We can use more than one antibacterial together, like one of them cover the gram positive, another medication cover the gram negative, and the third one will cover the anaerobic bacteria. So we try to use combination therapy for unknown origin infections. What is the disadvantage of this combination therapy? Why we don't prefer the combination therapy? For several reasons. Number one, there is a risk of toxicity. For example, when you use combination therapy for tuberculosis, anti-tuberculosis medication, there is a risk of hepatotoxicity. Anti-TBC, tuberculosis, when you use this combination therapy, there is a risk of hepatotoxicity. When you use, for example, some medication like static and sidal, we look on the therapy static and sidal, we look on the combination therapy and failure of therapy. We have tetracycline, we have penicillin, we have cephalosporin here. So when you have failure of therapy due to static and sidal, this also should take into consideration when you prescribe the medication to the patient. Okay, safety of agent, for example, they said, according to the medical literature, they said penicillin, amoxicillin, and ampicillin, and the group of penicillin considered the least toxic all of the antibiotic. So the least toxic of antibiotic will be penicillin in general. For example, on the other hand, we have chloramphenicol. Chloramphenicol is less specific, like antimicrobial, less microorganism specific. That means chloramphenicol may affect the bacterial cells plus human cells, and this is responsible for drug adverse drug reaction. So because it's not specific to bacteria, it also affect the human cells. So chloramphenicol less maybe specific for the microorganism, but also it affect the human cells, and this is responsible for serious side effect. Okay, for this reason, it's not popular in clinical use. Okay, route of administration when you have patient come to the clinic, outpatient clinic, with like mild infections, patient in the outpatient clinic, mild infections, we always prefer to use oral route of administration, like a tablet or capsule, ampicillin, amoxicillin, or cefalexin, or other medication. If the patient suffers from acute or severe infections, patient in the emergency room, we go the injection medication, could be IV or IM, depends on the situation. So with the emergency situation, we go the injection. Another important issue here, determine the route of administration. Not only like mild or severe, it's not enough for us. We need to look on something else. Sometimes we don't have the medication available oral, so we don't have oral medication from the group of antibiotic. For example, aminoglycoside, we don't have antimicrobial belong to the aminoglycoside prescribed orally and arrive to the bloodstream. Okay, so we don't have oral aminoglycoside, okay, to treat systemic infections. Okay, so we don't have it for arrive to the bloodstream. We have some, like neomycin, like ointment. Okay, so or like tobramycin ointment, but it's like oral on the skin with this medication. So the oral is not available, mainly available injection. Vancomycin to arrive to the blood. If you need vancomycin to arrive to the blood and practice systemic effect, we don't have vancomycin. It's only available like injection. So when you talk about injection here, we are talking about systemic effect. So we speak about systemic effect. Someone may argue with me that vancomycin available like oral. Yes, we have vancomycin oral, but this oral for local effect. So vancomycin for local effect, prescribe it oral. For patients suffer from Clostridium difficile, CD, Clostridium difficile colitis. Okay, Clostridium difficile colitis, we prescribe local vancomycin, oral vancomycin. This one will be remain in the GI system, vancomycin. But if you need like systemic effect, we need to prescribe vancomycin injectable injection to get the effect of vancomycin like in the blood. Okay. Okay, this group of medication, I will repeat it: aminoglycoside, vancomycin, amphotericin. This medication absorbed poorly from the GI system. Therefore, this medication prescribed like with the inside the parenteral roll, or like injectable for the patient. Okay, cost of therapy, do you need to take this one in consideration? Yes, it's very important. Multiple drugs may show comparable effectiveness. So we have so many drugs with a similar effectiveness, but they are vary on the cost of therapy, the price. Okay, so what we have here, we have patient coming to the clinic suffer from peptic ulcer disease, and when you do the endoscopy to the patient with the biopsy, and they found that the patient suffer from peptic ulcer disease plus Helicobacter pylori. Helicobacter pylori, this is kind of bacteria here. So for treatment of Helicobacter pylori, we need combination treatment, even to go with something called the triple therapy, or quadruple therapy. Triple therapy mean go to the proton pump inhibitor, number one, amoxicillin, clarithromycin. Okay, so we have three medication here: a proton pump inhibitor, amoxicillin, or and clarithromycin. So what we have here, if you sometimes the patient suffer from allergy towards amoxicillin, and we go the alternative here will be metronidazole when the patient suffer from allergy towards it. So you can see here if you compare between clarithromycin cost for the patient and metronidazole, you can see the difference of cost of therapy. Clarithromycin more expensive than metronidazole. Tetracycline is like cheaper than clarithromycin. Amoxicillin the same. So clarithromycin is like expensive medication. We have some alternative medication for the patient with peptic ulcer disease or for the treatment of Helicobacter pylori. So we need to take this in consideration, cost of therapy according to the patient situation. This was very important for us. Okay, another concept regarding antibacterial efficacy and potency, we have a concentration dependent killing concept. What that mean here, we have two group of medication, aminoglycoside and fluoroquinolones. You can see here as a concentration, they said as a concentration of antibiotic increased, so when you have increased concentration of antibiotic, when you have increased concentration of antibiotic, there is significant increase in the bacterial killing. So when the concentration of the bacterial concentration of antibiotic increase, there is an increased killing of the bacterial. So you can see the inverse relationship. When the concentration increase, there is increased killing of the bacteria. That give us maybe license to prescribe this medication once a day. Okay, once a day, high dose, high peak level, once a day, maybe achieve high level, high peak level. Okay, high peak level, and this mean high level of killing the bacteria, rapid killing of the bacteria. Okay. Okay, on the other side, on the other hand, what we have here, we have some medication depends on the time to kill the bacteria. We have two examples here. We have penicillin or beta-lactams. In general, beta-lactams, we have two types of medication there. Number one, we have penicillin. Number two, we have cephalosporin. And then we have macrolide, clindamycin, some glycopeptides. What they found there, even if you prescribe large doses for the patient, large doses from this medication, that mean high concentration, this will not lead to the killing the bacteria. This will not enhance killing the bacteria. So it's very important to remember that prescribing large doses from this medication are maybe achieve high concentration, but this high concentration, you can read it. I would like to highlight here some important issue here. Prescribe high doses, high concentration of these bacteria will not kill, do not significantly increase killing of the bacteria. This treatment here depends on the time. This medication required enough time, for example, 5 to 10 days to kill the bacteria. Okay, so for this reason here, when we prescribe it to the patient with peptic ulcer disease plus Helicobacter pylori, we need to treat like 2 weeks time for the patient with the amoxicillin. So we have two concepts: concentration dependent killing, aminoglycoside, fluoroquinolones, depends on the concentration of medication. We have time dependent killing. This group of medication does not give it depends on the concentration, but depends on the duration of therapy, time required to kill the bacteria. Okay, regarding drug resistance, we have two types of resistance. As you can see here on the screen, we have inherited resistance, acquired resistance. Inherited resistance, that mean the bacterial maybe has a system that that resists the antibiotic in their origin. For example, here we have some gram-negative organism and are inheritedly resist the vancomycin. So we have some bacteria inherited the mechanism of resisting vancomycin. So gram-negative resist the vancomycin, and you know that vancomycin considered like one of the drug of choice for MRSA, methicillin resistant Staphylococcus aureus, drug of choice. Okay, for vancomycin, but vancomycin they found is not effective against the gram-negative due to the inherited resistance. Then we have acquired resistance. What that mean? The medication, for example, the antibiotic was effective. Okay, then the medication become ineffective. And this one, we call this one acquired resistance. The microbial species are normally responsive to the specific medication, may develop more resistant strains. So the bacteria develop the strain that resist the antibacterial. So in the beginning, or from the first step, the bacterial or the antibiotic cover and kill the bacteria, but later on with the practice, they found that the bacteria developed system that resist the antibiotic. Okay, speaking about how this medication or how the bacteria resist the antibiotic, we have several mechanisms. Number one, we have genetic alteration lead to the drug resistance, or we have alteration in the protein expression. So genetic alteration, sometimes we can see some modification, spontaneous mutation on the DNA. If you have DNA here, we can see some modification here on the DNA that make the bacterial DNA resist the antibiotic, for example. This is number one. Number two, sometimes you can see this is a resist DNA segment may transfer from one bacteria to another. So sometimes this part of the bacterial segment resistance may transfer to another DNA in another bacteria. Okay, so this one will transfer here, and this make the another bacteria resist to the antibiotic. So you can see here we have spontaneous mutation. So we have mutation in DNA. This is the mutation in DNA. Number one. Number two, the DNA mutation will transfer from one to another, and this make the bacterial more resist to the antibiotic. Okay, this is number one. Number two, we have alteration in the expression of protein binding. So, for example, when you discuss the penicillin or amoxicillin, we know that amoxicillin penicillin affect the cell wall. Okay, here the cell wall, and in the cell wall we have something called penicillin binding protein, and sometimes we have alteration in this protein, and this will prevent penicillin to bind to the protein. So the second type of resistance could be alteration and expression of protein in the drug resistance organism. So we have modification on the target site. So you can see here we have modification in the target site, or decreased accumulation, or enzymatic inactivation. We have several examples for that. Okay, spontaneous mutation in DNA, they give us some example here. The Mycobacterium tuberculosis may develop the resistance towards rifampin when you use it as a single antibiotic. For this reason, we don't recommend to use rifampin as a single medication, or like monotherapy for the TB. We don't prefer to use this medication as monotherapy for the tuberculosis. Now we have the answer. Why we don't prefer use rifampin as a monotherapy for tuberculosis? Because there is a risk of spontaneous mutation in DNA, and the bacteria will be developed resistance to the rifampin. For this reason, we don't use rifampin as a single therapy. We prefer to use it like combination therapy. Moving to the second type of resistance, we have DNA transfer, and this could be through the plasmid mediation, and we can call this one inflammatory plasmid. And we have seen that in the previous slides here when we discuss the DNA moving from one segment to another. Okay, so what we have here, DNA transfer of drug resistance. We discussed that. Modification of target site when you have penicillin binding protein, penicillin. Okay, when we have penicillin binding protein. Okay, penicillin. Talk about penicillin binding protein. Okay, so what we have here, we have modification in this proteins, and this will resist the antibiotic, especially when we talk about beta-lactam. Okay, decrease accumulation. For example, here we have gram-negative organism can limit the penetration of beta-lactam, tetracycline, and chloramphenicol. So gram-negative organism prevent these medication to penetrate the cells. Resist beta-lactam, tetracycline, and chloramphenicol. Moving to the last one, enzymatic inactivation, beta-lactamase or benselinase. So we need here to remember a very important topic. We have the bacterial the bacteria developed maybe enzyme system to produce some enzyme called beta-lactamase or benselinase. So please remember the same name. Beta-lactamase is the same as benselinase. This enzyme able to destroy the beta-lactam ring. Okay, beta-lactamase or benselinase destroy the beta-lactam ring and make the bacteria resist to the beta-lactam medication such as penicillin and cephalosporin, other medication belong to the same group. So we have several, you can see several examples for rifampin, another one for the benzene binding protein, beta-lactam, decreased accumulation, and then we have the enzymic inactivation such as beta-lactamase or benselinase. Okay, uh, normally we use antibiotic. Normally we use antibiotic for the treatment. Okay, antibiotic for the treatment. But the question we use sometimes for prophylaxis purposes. So we can prescribe it for the patient. If the patient suffers from rheumatic disease, we can prescribe benzathine, benzathine for years of treatment. And some maybe medical literature, they said we use benzathine for 5 years. So you can see here we can use one injection every month, one injection every month for 5 years for the patient suffer from rheumatic disease, rheumatic heart disease. We can prescribe benzathine, benzathine every month for 5 years. This is number one. Number two, the second case, the patient come to the clinic and this patient has a heart disease or valve disease, or this patient implanted prosthetic devices, and this patient need to do some dental procedure. For this reason, this patient should be covered by the antibiotic to prevent endocarditis. So patient with the prosthetic devices, patient need to go to the dental surgery. This patient should be covered with the antibiotic before the dental surgery. Okay, another case. This is two example. Example number three. If you have patient in the maybe in the family suffer from tuberculosis or meningitis or in the hospital and you are in the close contact with this patient, you need to take antibiotic as a prophylactic treatment. So and for any individual who's in close contact with a patient with a tuberculosis or meningitis, we need to use antibiotic to prevent infections. Okay, so this is number three. Number four, prior surgery, for example. If you have surgery, especially contaminated surgery on the abdominal, we need to prescribe antibiotic before surgery to prevent infection. If you have pregnant women suffer from infected by HIV, we can prescribe zidofudine to to protect the baby from getting the HIV viruses from the from the mother. So we have now several examples for prophylactic treatment of antibiotic. Here we have some medication. Here you can see dental prophylaxis if the patient suffers from some certain heart condition to prevent an infective endocarditis. Surgical prophylaxis depends on the situation here. Some maybe popular medication antibiotic could be used for the vancomycin, clindamycin, or cefazolin. If the patient maybe travel to the area maybe epidemic with some infections such as malaria, for example, sometimes we use the doxycycline or chloroquine, hydroxychloroquine, to prevent infection from malaria. So we have several examples for prophylactic use of antibiotic. A patient with heart disease, rheumatic disease, surgical procedure, xylophoene. Okay, is there any complication? Here we talk about maybe something about adverse drug reaction or like toxicity or like precaution. So we have several and cautions, warning, for example, also. Okay, so adverse reaction, toxicity, precaution, or warnings. Hypersensitivity, number one, penicillin will be the most popular agent in causing hypersensitivity, followed by bisulfonamide. The hypersensitivity could be mild. The hypersensitivity could be mild and could be serious hypersensitivity, and the patient maybe could suffer from the side effect could be ranged from urticaria to anaphylactic shock. So depends on the situation here. Could be urticaria only, could be anaphylactic shock. Here we have different approach. If the patient come to the clinic suffer from urticaria, we can prescribe only for this patient antihistamine. But if the patient come to the hospital suffer from anaphylactic shock, this one considered like emergency case, and this patient should be treated with epinephrine, for example, injection, cortisone, and other medications such as antihistamine. And you can see here emergency treatment. So it depends on the case for hypersensitivity. Okay, we're done with this one here. We're moving to the next one. Okay, the side effect, adverse reaction, complications, direct toxicity, aminoglycoside. Aminoglycoside may cause ototoxicity, may cause renal toxicity. We call this one nephrotoxicity. Okay, so the second one, direct toxicity. Okay, moving to the third one, super infections. Okay, when you prescribe broad spectrum antimicrobial or combination of treatment, so the question now for everyone, give me medication considered like broad spectrum antimicrobial. So I'm asking about medication considered like broad spectrum antimicrobial. Okay, I will type here tetracycline, chloramphenicol. Okay, broad spectrum antibiotic. So what happened here when you prescribe a broad spectrum tetracyclines, doxycycline, monocycline to the patient? Okay, the broad spectrum will maybe inhibit the normal microbial flora. So we have flora in our GI system, gastrointestinal system, and the respiratory system. So we have in the GI system, respiratory system, with the genitourinary system. Okay, what happened here? The flora will be inhibited. So broad spectrum will inhibit the flora, and this will lead to the permitting overgrowth of opportunistic organisms such as fungi or other resistant bacteria such as Clostridium difficile, and this will cause colitis, Clostridium difficile colitis, or pseudomembranous colitis. Okay, the last slide for this introduction today, introduction to this is the kind of algorithm for treatment bacterial infections. This is your clinical practice or our clinical practice. You can imagine now you have patient come to the clinic suffer from infections. First of all, I have to look on the clinical symptoms and signs. Does the patient suffer from fever, for example? Does the patient suffer from any other symptoms? Look on the skin, or any infections, or any sepsis, for example, for the patient here. So we look on the sign and symptoms, number one. Number two, we ask ourselves, or we can ask for the for microbiology, like bacterial cultures. Does the patient carry the bacterial culture or has a positive microbiology? If you don't have symptoms and don't have microbiology, in this case, if the answer will be no, okay, we ask ourselves, is this the case likely to be bacterial infections? If the answer yes, okay, so we look on the what type of bacteria we are going to use according to the predominant organism and sensitivity. For example, if the patient suffers from pharyngitis, we know that pharyngitis mainly by occur by gram positive, so we can prescribe some amoxicillin and ampicillin to the patient, or like first generation of cephalosporin. Okay, we need to treat with the appropriate antibiotic. If the patient suffers from urinary tract infections, and normally urinary tract infection, and this is normally happen with the gram negative bacteria, so we can prescribe fluoroquinolones such as ciprofloxacin for the patient. So we have so many options for the patient. If the question like it's not likely to be bacterial infections, okay, in this case no need for the treatment. So this is the other option. Okay, now we move to another parts. The patient come to the clinic with the clinical symptom and sign. We have positive microbiology. The cultures come in, and we have the bacterial sensitivity profile available. Okay, so this one in the maybe we can use appropriate antibiotic according to the culture sensitivity. According to the culture sensitivity, we use appropriate antibiotic. If you don't have culture sensitivity, again we go back to the predominant organism and sensitivity. Okay, we need to consider also here we prescribe the medication with maybe enough with enough dose and duration. Very important, dose and duration. Then we consider other measures. For example, does the patient suffer from abscess? Do we need to drain the abscess, for example? The length of the treatment, as we discussed that here. Now we, after all these dose and duration, does the symptoms improve in this patient? Sign symptom improve. That's great. We can consider that by looking on the CRP, ESR, temperature, white blood cells. If this all happened, the answer was yes, so we complete the treatment. So this will be great to follow up. This is the organism, how to treat patient with the infection when it come to the clinic. Okay, this conclude our antimicrobial introduction part 2. In the next session, we are going to speak about the category of antimicrobial according to the chemical structure, according to the site of actions. On the, for example, we are going to speak about a group of antibiotics that affect the cell wall, group of antibiotics that affect the protein synthesis, and we have nucleic acid synthesis, then we have RNA polymerase, DNA polymerase, we have metabolism, folic acid metabolism. So we have several group of antibiotic. Should be maybe we're going to discuss it in more details in the next session in part 3 of antibiotic. Thank you everyone, and have a great day.